Good afternoon, everybody. Thank you so much for joining our webinar series today. On behalf of Georgia HSMA, we really appreciate everyone joining us and taking their lunch time. Our today's session is called Successfully Implementing Transformational Technology in Hospitals and Health Systems. And we really have a treat in place for you guys. We have a wonderful speaker and a longtime friend, Mr. Glenn Pearson. So I'm very excited to hear his session and have him join us today. Glenn, thank you so much for taking the time and joining us today.
My pleasure, and thank you for the kind words. Can I bring you with me when I speak in person so I can get such a nice introduction like that again?
Oh, absolutely.
Okay, great. Well, let me tell you what, thank you for joining us, everybody. I know, as Stephanie said, this is a busy time for people, and we appreciate your taking the time to sit through this. And I hope if you're eating lunch, you can enjoy your food at the same time and pay attention. Let me tell you what we're going to cover. You can see we have a lot of material to cover here. First, I'll give you a little bit of background on myself, just so you know who I am and why I know something about this topic. We'll talk about a couple of objectives and takeaways. Then we'll look at why this topic matters, give a status of the industry of healthcare technology, and then look at the two big buckets of healthcare technology, followed by the four fronts of the health technology revolution. So all that part is setting a backdrop for the second part, which is dealing with requirements for success in getting healthcare technology implemented and then avoiding some of the pitfalls that are involved. So I hope that makes sense. And there's a lot of material to cover, so I will be speaking rather quickly. I'll try to leave plenty of room at the end for discussion and interaction. So first of all, just a little bit of my background. I was Executive Vice President at Georgia Hospital Association for more than 19 years, and I worked with various areas, including finance, technology, data, mHealth, communications, public relations, and a few other areas. So I love technology, although I'm not a tech guy myself. I'm not a CIO or anything like that, but I am bringing the executive perspective on how technology is important in helping change healthcare delivery. So the company I founded a couple of years ago is called Pearson Health Tech Insights, and we really work with three groups of clients. One is technology developers, some of which are from the healthcare industry, but many of which are relatively new. And we provide orientation and strategy for how to successfully get their products listened to and introduced to healthcare setting. Another group, of course, is providers, helping them see how healthcare technology can make a difference in accomplishing their goals. And then the third group is investors, trying to figure out who they should be spending their money with. So those are all three important groups. So some of the objectives of today's talk, I would like to provide you with a framework to help you understand technology's many complexities, including why this is important, what the status of the industry is, and then providing an outline for categorizing technology development. So the framework to judge this technology is a very broad area. You say health technology to 50 people and you get 100 different opinions as to what that is. So I'd like to give you some framework to understand how that all fits together. Secondly, give some strategic insights to help you see how technology can achieve your corporate goals. And then thirdly, give some practical advice to help you successfully implement emerging technology initiatives. So that's what we're trying to do. What the session is and what it is not. It's not designed to be in any way technical. Like I said, first of all, I'm not qualified because I'm not a tech guy myself. It's not designed to be technical. It's not designed to deal with the details of EHRs, IT infrastructure, interoperability, or any compliance requirements. So it's not dealing with any of those things. It is designed to provide an overview of technology's strategic nature and role and how to get technology implemented. So that's really what we're after, the strategy piece. And I imagine there are people from various parts of the hospital world and some vendors and people like that. So this is really helping provide a strategic framework to help maximize the likelihood that technology will be successfully brought into your organization. So why is this whole topic of health tech important? A couple of reasons. It really relates to the new world of healthcare delivery. I like to divide things into categories. I find that helpful and help them not pigeonholing, but it helps me think through the complexities. So as I've thought about how technology is having an impact on healthcare delivery, there are really two aspects of that. One is the reactive, and the other is the proactive. So under the reactive side, I have compliance and new patient payment incentives. So what I mean by that, and I'll talk about this in a little bit, the proactive side really has to do with clinical breakthroughs and coordination of communication among the providers and between providers and patients. So let's look a little closer at the reactive piece. And there are a couple of active aspects. One is compliance. Of course, we have privacy issues created by HIPAA and other privacy requirements. And then there are interoperability requirements from MACRA and 21st Century Cures Act, which is really more dealing with the vendor community. But everybody has to get up to speed on the compliance aspect of healthcare technology, if for another reason than to avoid penalties from federal standards. Okay, the other side of the reactive is the new payment incentives and penalties, and we all know about the value-based purchasing and readmission reduction program, hospital-acquired conditions requirements. So there are new environmental factors that come into play where providers have to be meeting these standards in order to not be penalized, and also to put in positive terms to take advantage of payment alternatives that are out there now that didn't used to be. So the implications of not complying with reactive requirements are financial penalties through either reduced payments or some outright penalties, depending on your category, but then also potential legal action if you're not complying. And then equally important is the public relations aspect of fallout. If somebody's exposed as not complying with the new requirements, that's not good for anybody's public perception. So those are some of the reasons why we need to be thinking about this. And here's how we deal with some of the reactive requirements. This is very high level, and I'm not telling you anything that you probably don't know, but I like to sometimes state the obvious just to reinforce what people need to think about. So first of all, make sure that your organization thoroughly understands the requirements. You can't comply with something you don't understand. Then you have to commit adequate technical resources and expertise to fully comply. And then third, set up monitoring processes to respond to the changes in requirements and make sure you're meeting all the requirements. So those are kind of the reactive pieces, which I call that cost of doing business. Whether you like it or not, you got to do it. And hopefully you're doing it with a good attitude, because, these are all well-intentioned things and they're designed to improve care and, help keep data secure and all that kind of stuff. But you have to do it whether you like it or not. And here are some of the steps you need to take to comply with that. The proactive side, I think, is more exciting to me, because this is where things like clinical breakthroughs and the opportunity to take advantage of population health management, coordination, care coordination across the continuum. This is what's really helping to improve the quality of care that hospitals and physicians and other providers are offering to their patients. And this is where healthcare changes in a very positive way. So I'd like to read a statement from a well-known health expert. You heard it first. It's virtually impossible to maximize quality, manage populations, coordinate care, reduce costs, manage resources, comply with regulatory requirements, and operate under the new financial realities without tapping into the emerging technologies that were not around even 5 years ago. And that was said by Glenn Pearson, and you heard it first today, because I just said it, and I'm kidding when I say well-known healthcare expert, but I really mean this, that as I've interacted with providers and developers of technology and all that, it's absolutely amazing in a very positive way to see how technology undergirds all these things that we've been saying for decades we're trying to do, like improve quality, improve efficiency, coordinate care, and you really can't do that very well. We've been trying for decades and haven't done it very well, but guess what? Technology is here to support that, and it can be a strategic priority for healthcare delivery organizations to take advantage of moving forward with accomplishing all these goals. So again, I'm a little bit facetious when I say you can't, that I'm the expert saying that, but after my interaction with all these folks for many years, I think we're at a very exciting tipping point in moving forward with technology enabling our strategic objectives. Now, there's a reality that we have to face, and that's what I call the great divide in the leadership side. Many hospital executives and physician executives get this, but some of the more traditional clinicians and executives tend to avoid technology, and I have two little stories about that. I wrote a blog about a year ago called "Would You Rather Manage the Nuclear Power Plant or Buy Healthcare Technology?" And, usually people chuckle when they hear that. They say, what do those two things have to do with each other? Well, if you think about it, I can be a terrific manager, a great executive, a great leader. I don't know a thing about nuclear power plants. So if you ask me to manage a nuclear power plant, I'll do it and I'll do a decent job, but I'm not going to necessarily be emotionally invested in it in the sense of coming up with creative ideas and saying, well, gee, I wonder if we change our strategy on this, if that would help accomplish these goals, because I don't understand it very well. And I'm entirely at the mercy of the technical experts, the scientists, the nuclear power guys that are saying, oh, don't worry, nuclear reactor number 2 is fine, no chance of a meltdown. Well, guess what? If it melts down, who do you think is going to lose his job? It's going to be me, because I'm in charge. At the same time, that person can come to me and say, man, we're in a terrible condition. We need to double our capital budget or we will have a meltdown. Well, how do I know if they're telling the truth? Not that they're necessarily trying to deceive me, but maybe their judgment's wrong. And it's a little simplistic example because there's certainly ways to verify these things. But when you think about it, the executive and the leader never likes to be asked to provide creative input and management of something that they don't understand. And I've talked with many healthcare executives who feel exactly that way about technology. In fact, the second quote there, I've been able to avoid this for my whole career. I was talking to somebody who's been in a healthcare executive for 28 years, and he made the comment to me, he said, I've been able to avoid technology my whole career, and I have 8 years to go before I retire, and if I can keep it that way, I'll be happy. So that's my way to say you're going to find within any organization, I'm not being critical of people because they're very talented and they have skills that I don't have, and I'm not in any way criticizing them, but that's part of the climate that technology has to operate in, and those are some things that you're going to find. So that's kind of some of the background of where we've come from. And now let's look a little bit at the status of the industry. Where are we as a healthcare industry and specifically as it relates to technology? Clearly, we're in a rapid growth mode. I mean, everybody who has anything to do with this sector is saying that in spades. There's no question about that. But they'll go on to say immediately afterwards, we're still woefully behind other industries like manufacturing and retail and every other sector except healthcare. We're much further behind. Usually the number I hear thrown about is about 10 years behind where other industries are in terms of their adaptation and implementation of technology. So why is that? There are 4 reasons that I've thought of. First of all, we're a splintered industry. If you think about it, we have hospitals, we have physicians of many varieties, many specialties, primary care, all kinds of subspecialties. There are nursing homes, there's other long-term care facilities, there's hospices, there's community health centers, there's federally qualified health centers. So we're not a monolithic industry, and typically each one of those sectors has developed its own approach toward technology, and most of those were never put in place or designed to think that someday down the road we may need to interoperate between, say, a retail pharmacy and a hospital EHR. Nobody thought that that would be necessary. And again, I'm not being critical. It's just the fact that we've grown up. All these things were done in isolation. So when you try to combine things together, it's extremely difficult, both from a technical standpoint, but also operationally. We've never had to have retail pharmacy interacting with hospital ICUs before, but now we may have to do that in some cases. So in that, the second bullet speaks to that as well. Peter Drucker, the famous management expert, has made this statement, which I think is pretty astounding coming from somebody like him. He says, healthcare is the most difficult, chaotic, that's a key word, chaotic and complex industry to manage today. And that's because of the complexity and so all these other factors. Another factor is the conservative nature of clinical care. When you're asking clinicians to adopt new technology, their primary objective is to make sure that the patients are receiving the best care they can. And if you're coming up with a technology that touches the patient in any way, and it's unproven or there's some controversy or some question, they're not going to have anything to do with it because their first job is to do no harm, as the Hippocratic Oath says. So it's a very conservative industry from that perspective. And then, of course, the last one is just the expense. You know, technology is very expensive to implement, and it takes a lot of time. It can be very disruptive. So these are some of the reasons why healthcare is so far behind other sectors. But as I said, fortunately, we're changing now. And the question becomes, why are we changing now when we've been so far behind? And again, I've identified 4 factors that I think feed into this. First one is the internet revolution of the late 1990s. And that's completely changed the mindset and expectation of business on every front. So for example, if you want to order a pair of pajamas and you go to some website or some athletic equipment or anything, and you see something you like, don't you get a little bit annoyed if there's not a way to instantly order that online and, put in your credit card and get the stuff the next day through Amazon or, some other site? We've gotten so accustomed to that it's just, if you find a company that can't do that, you say, what century are they living? And the example I like to give on that, 20 years ago, I set up, my wife and I spent a month in Europe, and I took the bold step of finding hotels and train connections and everything else on the internet. And I got to tell you, when we arrived in Europe, I wondered, are we going to have any really hotel rooms? Are they actually going to be there? Because it was so early on that I had never tested it. I was just kind of taking it by faith that it would work. Well, we're going back later this year, and I can't believe how easy it is to get things set up, get confirmations instantly, get emails, even aggregation of my itinerary that I didn't ask for, from American Airlines, because they're linking together all my hotel rooms and all that stuff. So it's completely changed the way we do business in many sectors, and that's proliferating to expectations of patients. Patients want transparency, they want information, they want ease of scheduling, and it's just a requirement now that wasn't there before. The second reason is that the cloud has made it a whole lot easier to conduct business without having to resort to enterprise technology in the way we did years ago. And right along with that is the whole SaaS thing, software as a service, and it makes it a whole lot easier for the IT folks to maintain current status of software and interoperability and all that through a single location. And then finally, the explosion of smartphones and tablets, which goes back to the consumer expectations. This year happens to mark the 10th year anniversary of the iPhone being introduced and proliferating. Now, there were smartphones before iPhone came out, but for some reason, Apple has the magic touch, and it got to the point where everybody has a phone now and also tablets. And we're only at the 7-year date for iPad. And I don't know if you remember back when it was introduced in the year 2010, a lot of critics were saying, why the heck did Apple come out with this silly tablet thing? I mean, it's not a laptop, it doesn't really do computing very well, and it's not a phone, so it's just a bigger phone without phone capability. Why would I want one of those? And for the first 3 weeks, that's all you heard. Well, guess what? All the experts were wrong. And I defy you to find anybody who doesn't have a smartphone and or a tablet now, anybody in the business world, because it's just proliferating. So these factors are creating demand on the part of our patients to have access to much higher levels of technology than 10 years ago. So this is an interesting comment from futurist Eric Topol. He's talking about where smartphones are going. He says that smartphones will soon be able to capture physiological data from any organ or system, run routine lab tests, perform medical grade scans, track environmental exposure to hazards, do most of physical exams, and connect with physicians and others instantly. So these are all capabilities that are under development now. Some of them are already here, and they're continuing to be refined, and that's kind of where things are and are going in the future. And right hand in hand with that, another futurist, Joe Flower, is referencing the Internet of Things, which is smart devices connected to the internet. And he's referencing sensors in toilets, mirrors, TVs, health watches, contact lenses, and smart patches and implants, which can provide data to the appropriate clinical people that are tracking where patients are going and what their health conditions are. So, summary, why healthcare technology matters. First of all, there's new demand from the environment through regulatory requirements, payment changes, and patient expectations, coupled with new capabilities like incredible medical breakthroughs and revolutionary communications capabilities. So that's a summary of kind of all, kind of why this matters, why it's changing, what the expectations are, and why this is so exciting. So next, I'd like to look at the 2 big buckets of healthcare technology. Again, I like to put things in categories because it helps to think things through. And my 2 categories are traditional technology and then emerging, disruptive, transformational technology. So under traditional, I've already referenced this. These are things like IT infrastructure, EHRs, compliance, things like that. These are the things that you have to have in order to be in the patient care business. And I don't hear anybody advertising that people should visit their hospital because they have a computer system or because they have EHRs. I mean, that's expected. That's like saying, gee, come to our hospital because we have elevators or we have an HVAC system. You know, you can't do that without having these technology things in place. So traditional technology is expected, and it's not really changing a lot, although, you know, EHRs certainly are moving in that direction. But where the excitement to me comes is in the emerging, disruptive, transformational technology. And you see the list of things, you know, telemedicine, telehealth, mobile apps, big data, predictive analytics, and all those other things. So there's a lot of things that are going on that are changing in many small ways. 3D printing, genomics, DNA sequencing, all these things are really moving the ball down the field in terms of how we provide care. So again, I like to put things in categories. So I've divided these emerging technology categories into 4 subcategories. Those are patient touching. Number 2 is personalized medicine. Number 3 is communications. And number 4 is business functions. So let's look quickly at each of these. So by patient touching, there are 3 categories of those: diagnostics, intervention, and devices and implantables. And let me just give a little more detail of each of those. By diagnostics, I mean things like wearable technologies, teleradiology, MRI, things like that, that can literally diagnose patient conditions with more precision than previously. Intervention involves things like stem cell therapy, robotic surgery, laparoscopic surgery, things like that, where new technology is actually brought into how I take care of patients once they've been diagnosed. And then devices and implantable, things like cardiovascular implants, bionic limbs, 3D printing, and things like that. So those are things that literally touch the patient that are technology driven. The second category is personalized medicine. And there are 3, some of the categories here are evidence-based and data-driven customization of care based on my personal traits and circumstances. So this involves a merger of population health, big data, predictive analytics, and these can fall in the categories of either largely clinical, evidence-based medicine, or largely care coordination, evidence-based medicine. So let me just give some implications of that, again, by Eric Topol. He's talking about clinical algorithm recommendations. Everybody's heard of IBM Watson. And he's saying that what we're going to have in the future is IBM Watson to the 4th power, not times 4, but IBM Watson squared, tripled, and then quadrupled, to the ability to identify clinical problems and make recommendations for intervention. And he also talks about a planetary medical knowledge resource, which is a pretty mind-boggling area. So what he's saying is that we're going to have so much information at a planetary level to know so much more about medical conditions than we do now, that it's absolutely, you know, incredible where we're going to be in just a few years. The third category is communications between patients and providers, and then among providers. So what I mean by that is communications among providers, things like electronic health records, teleradiology. This allows different provider groups and individuals to talk to each other to provide information back and forth in a way that's far more efficient than sending paper referrals, or, you know, maybe getting a report back from the specialist to the primary care physician 2 weeks later, if at all. But electronic communication can facilitate that. And then in terms of communication among providers, this is post-discharge information to track patient progress and determine whether patients are actually following the care plan, how compliant they are. So these are all very exciting communications ability that weren't there again a few years ago. And then in the business function areas, there are clinical applications of business functions and non-clinical applications. And what I mean by the clinical applications is things like lean process improvement. And these are data-driven, multidisciplinary teams that are looking at outcome measures and looking at efficiencies and processes that, you know, the processes are not clinical per se, but they touch on the clinical processes for the purpose of improving quality and outcomes. And then you have non-clinical applications, which are your standard business functions like scheduling of ORs and HR functions for a hospital and that type of thing. So I know I've gone through this quickly, so let me give you a summary slide about the four fronts of the healthcare revolution. So again, they're patient touching, and there are three subcategories: they're diagnostics, intervention, and devices and implantables. Then there's personalized medicine, which some of it's clinical and oriented, some of it is in coordination of care. Then you have communications issues between patients and providers and among providers. And then finally, you have business functions, which are subdivided into clinical applications and standard business activities. Okay, so all this, by the way, is backdrop as to explain why this is an important topic, why things are changing, how we need to think about these things to make it easier for people who may not necessarily be technology oriented to think through how they can use technology to support the clinical and strategic objectives that they have. So my last section, I'd like to talk about the four fronts that I just mentioned and requirements for success to get these technologies implemented in your organizations. So the first couple of slides deal with things that all four of the four fronts, the patient touching, the personalized medicine, the coordination, and the business functions, all these require these factors to be in place. The first one is very obvious, but again, sometimes it's very important to state the obvious. You have to get internal support of key staff. And if you've ever worked in a hospital or a large physician group or even in a vendor organization for that purpose, you've probably seen a project torpedoed because one or more critical people who have to sign off on this don't agree with it. And sometimes the reasons are very understandable and valid, and sometimes you wonder why they're opposed to things. And I'll mention some of them later on, but you know, you have to assess the landscape, find out who are the people that have to be behind this, or putting it in a negative way, who can torpedo this if they're not behind it, and what does it take to get them on board? So before you go too far down the road, figure out who it's going to take to be supportive of this. The second one, which is related, is getting underlying infrastructure to support that. And that comes in two pieces. One is IT. Anything that, as soon as you mention the word technology, it immediately gets over to IT, whether or not it really is an IT related thing. But people, again, clinicians or executives who aren't necessarily technology oriented, as soon as they hear the word technology, think IT, and they think IT needs to sign off on that. And that creates an extra step, and I'm not picking on IT folks because they're highly worked and they have lots to do, and it can create some problems. Make sure if it is something that is touching IT that you understand the implications of getting them involved early. The other aspect of that is having an ability to modify operations. So, and that leads right to the next bullet, which is the ability for something to be actionable. So, for example, if you do a big data-driven study, you know, through clinical process improvement and, you know, Lean Six Sigma and all that, and bring some technology in to improve what you're doing, if the conclusion of all this technology and operational stuff is that your ER is too small and you need to build your ER bigger, well, if you're landlocked or you have no capital budget, how helpful is it to say, you know, this technology will help us figure out that our ER is too small? Well, guess what? I can tell you that without even doing the study. So you need to have, if you're trying to introduce a new technology or a new analytical approach, make sure that whatever your conclusions are going to be are things that the organization can absorb from an operational standpoint. Okay, the fourth requirement on this page is to have a solid and credible ROI. And I can tell you, this is probably the biggest challenge that I see vendors facing or internal enthusiasts who want to get a project implemented. And they make three mistakes in ROI. And actually, I'm in the midst of a 3-part series on my blog. And by the way, if you're interested in getting my blog, I have my contact information on the last slide, and just drop me an email and I'll be happy to add you to my blog list. I send out blogs about every 3 weeks. And 2 blogs ago, I talked about this first pitfall of ROI projections, and that's selling a project on efficiency improvement when those efficiencies can't be captured. And the example I gave is, I've seen this happen, I can't tell you how many times, and in my blog is the example of a technology product that is designed to increase the efficiency of a PT department. Okay, so they say, well, we can cut 5 minutes per procedure for your physical therapist, and they do, I'm just making these numbers up, 10 procedures a day. So that's 50 minutes a day we're saving. And by the way, we're, you're paying your therapist $70,000 a year. So do the math and you'll say whatever the numbers turn out to be, and you can pay for the project that. Well, that's a nice theory. But if you think about it, it's wonderful that you're saving 5 minutes per procedure, but all that means is that I've freed up 50 minutes of that person's time to do other things that they probably weren't able to do before, which is great to do, but you really haven't saved any money because they're still on the payroll for 8 hours and not 7 hours and 10 minutes. So to say you can write a check from that 50-minute savings is never going to happen. So a lot of projects are sold on that. I would say that close to half of the vendors I talk with have some version of that projection as part of their savings, and hospital people have seen that a million times. And they're extremely skeptical about that. So what I tell my clients is that I'm kind of the bad news guy. I tell them things that they don't necessarily want to hear, but if they're a vendor, I'm preparing them for what they're going to hear and help them think through very defensible ROI numbers. So that was my first blog from a few weeks ago. The one I just did last week was promising additional revenue. So vendors will say, okay, well, maybe you're right. Maybe we can't, write a check out of the time savings, but you can bring in more patients and bring in more revenue. Well, that's a nice theory too. And that happens sometimes because there are some clinical areas that are literally turning patients away because they don't have capacity. Or if I call up and say I'd like an appointment for, an orthopedic person and my hip is really killing me, and they say, well, that'll be 3.5 weeks before I can see you. Well, in some cases, they might say, I can't wait that long, I'll call somebody else. But I would say certainly many, if not most clinical areas, that's not the case. So just to say you're bringing in new revenue is probably not true for most clinical areas. So that's not helpful. It's not likely to really happen for most clinical areas. So then the third line of defense, and I'll be writing about this in about a week or so, is people say, well, yeah, maybe we are bringing in, even if we are bringing in new revenue, that's great, or new patients. The third question becomes not recognizing that not all new volume is a financial plus. And there are a couple of categories where that's true. One is if it's an uninsured patient where they typically don't pay anything or very little of what they actually expend, or if they're under a fully capitated system, which is not all that common, but there is a little bit of that goes around. So if they're taking a patient that's in a capitated situation, you've already gotten all the money that you're going to get out of them. So bringing in new volume is not necessarily helpful. In fact, it could be counterproductive because you're incurring additional costs. So again, I don't want to be the bearer of bad news, but ROI mistakes are very prevalent, and many providers, hospitals, and physician groups are very skeptical about that because they've heard these promises made over and over again. So if you're either an internal enthusiast or a vendor trying to get your technology implemented, you need to realize that you're probably going to run into some objections around your ROI projections. So just be very conservative. I tell people, if you walk through your logic with them and you invite them in to tell you, well, what percentage of the savings you think I can capture, and how many new patients you think we might actually get, bring them into the equation, then by the end of that ROI exercise, you've done one or two things. Either you've shown them that your ROI numbers are solid if they bought into some of your assumptions, or you've demonstrated that you're a credible source, not trying to dazzle them with numbers that aren't real, and your likelihood of being trusted has gone up. So just be very careful in how you present your ROI numbers. Okay, so those are the mistakes. Let me back up for a second. These are the 4 front requirements, or all 4 fronts require these things: internal support of key staff, underlying infrastructure to support, ability to be actionable, and then solid and credible ROI numbers. And then I have some comments on each of the 4 buckets, some specific additional requirements that are touching each of these other categories. So under the patient touching categories, 2 other things that you need to watch out for are the need to be compliant with rigid regulatory requirements. So anytime you're touching things that are patient touching, you have all kinds of FDA things. You might have some clinical research things that have to be complied with. So just be sure that you've checked through with all the regulatory agencies, including the hospital's internal quality assurance committees and all the things that maximize the probability of positive patient outcomes. And right along with that is the need to have support from key clinical staff. And all it takes is one person on the clinical side to object to what you're doing, and you're going to find a huge amount of resistance that you don't want to run into. Okay? So those are the patient touching buckets, additional requirements. The second category on personalized medicine, there needs to be rock solid underlying data and rock solid clinical algorithms, because it's pretty likely you're going to get possible challenges from clinicians as to your methodology. So again, there are 4 aspects that I've seen come up that create problems. Sometimes it's disagreeing with underlying clinical logic. Every clinically oriented project has as underlying principles certain ideas of how care is delivered, disease progression, that type of thing. And you might run into an area where one of your key clinical people doesn't agree with that approach toward providing care. So you need to think that through. If it's a data project, I've heard this over and over and over again. Well, the data you're using is two years old. I'm not going to trust it. And that's a legitimate concern, but it comes down to, and we heard this all the time when I was executive VP at Georgia Hospital Association. I led the data area, and people say, well, your data's a year and a half old. I don't want to use it. And I say, well, neither do I. But guess what? We don't have any newer data. If you have newer data that we can incorporate into what we're doing, I'm happy to use it. But old data is better than zero data, and we need to realize it is not exactly contemporary, and some things may have changed, but it sure is an awfully good starting point. So just be prepared to have people challenge data based on age or quality of the data, which is a legitimate thing, and that's why it's important to clean up the data as best you can. The third objective on personalized medicine is resistance over the idea that you're telling me that the machine can do it better than I can. And you have to respect that on the part of physicians, because medicine is certainly a science, but it's also very much of an art. And a lot of times, if you look at some of even the IBM Watson stuff, a lot of times you'll end up with competing diagnoses that are sort of equally or almost equivalently probable. And sometimes there's a gut feeling that a physician may have over one approach over another that may not necessarily be demonstrable clearly from the data. It's not irresponsible, but sometimes they just have a gut feeling. In fact, it used to be that physicians would use all of their senses, and they still do to some extent, to diagnose a patient, including the sense of smell. And that's not going to necessarily be picked up in a data algorithm from IBM Watson. So, physicians are understandably sensitive to the implication that they're not as smart as a machine, but frankly, the algorithms that IBM Watson and other big data can do outstrip by far what physicians can do in many cases. So just be sensitive to that and be very respectful. And then if there's any kind of a clinical project, or actually non-clinical too, that involves peer comparisons, one of the things that always comes up is, well, you don't have the right peers in my comparison group, especially if it's a project that's geographically based, where you're looking at standard of care in the community. And if there's one major health system that's not part of it, that creates problems. But again, I think a way to handle that is to say, perfect data is ideal. We don't have perfect data. We're dealing with suboptimal data, but some data is better than no data. We're not going to hire or fire people based on this data. It's a starting point for discussion, and we're not using this to bash anybody over the head. We're using it as a point to say, let's discuss where we're at and what this data tells us, and how can we supplement this with other information that may not be in the data to help us come to responsible tentative conclusions that we can test out in a real world environment. So the key word in all this stuff is humility and sensitivity and respect for the people with large, bodies of knowledge behind their opinions. So those are some of the pitfalls around personalized medicine issue. Under the communication side, a couple of things to think about there is identification of key communications contact points and connection points. So if you're trying to coordinate care among post-discharge providers and you're leaving off home health, and that's a key component of the care plan for that individual patient, that's a pretty big gap. That there may be things going on in home health or home health not being brought in like they should, and you have no way to know that, and that's going to provide a gap in your knowledge of how the patient's responding to the post-discharge care plan. So identify the key communication points and make sure they're in the loop. And again, there's technology around today that will help facilitate the communication among all those different groups. And then finally, you have business associate agreements that have to come into play, and also privacy agreements, privacy requirements to make sure that you're not getting involved with companies that are less than prudent and less than complete in their handling of data. So those are some of the communications pitfalls to avoid. And then finally, on the business function, just to be complete, I really didn't think of anything beyond the requirements for all of the standard issues that are specifically related to the business function side. So let me just back up and go through these to rehash some of the requirements. Get key support of key staff from within your organization. Make sure you have underlying infrastructure and support. Make sure whatever technology you're trying to bring in can be brought to an actionable level by the appropriate departments. Make sure you have solid and credible ROI numbers. Don't oversell the efficiencies that can't be captured. Don't promise additional revenue unless you can support that. And you need to keep in mind that just because you're bringing in new patients doesn't necessarily mean it's a financial boon to the organization. And on the patient touching side, be careful to make sure you find out all the regulatory requirements, get support of key clinical staff. And on personalized medicine, make sure you've thought through some of the challenges you're going to find around clinical logic, imperfections in the data, either because of old data or less than perfect data, and so it's going to be less than perfect. Resistance over the idea that you're telling me that a machine's smarter than I am, and then lack of local peer providers and comparison sets. And then on the communication side, identification of the people you need to be connected with, and make sure you have in place all the privacy and BAA requirements that the privacy laws require. And then my last slide, I have a few more global pitfalls that I didn't identify. Underestimating the possible disruption to existing operational processes or concern for additional workload. Now, this is really important. When you're introducing new technologies, there are things that are not necessarily going to be happy on the part of people who have to change their workflow. They might be saying, well, you're asking me to do things I didn't have to do before, and I'm not sure I like that. Right along with that is underestimating resistance from people or departments whose status or revenue could be threatened. So every time you introduce efficiency, that could imply certain reduction of FTE. And if I have control over a certain budget area, and I hear you saying, well, we can reduce your staffing by 3 people, no one's ever going to admit that and say, oh, I don't want to do that. But you're really cutting into their territory. So either by asking them to do additional work that they may not have wanted to do, or by threatening their status within the organization, that's not necessarily a good thing to do, or at least be aware that that could be a factor. And then another global pitfall is having to run all technology-related offerings through IT and getting squeezed out by other priorities. And I've referenced that a little bit before. And I'd say this very respectfully, IT is very busy. They have a lot on their plate, and sometimes it takes months to get them to even look at something. So if you have a technology-related offering, you need to make sure that you at least recognize that that's going to probably delay things. And if there's a way to legitimately get it not brought through the IT department without offending them or trying to do an end run, that's a good way to make sure that you're moving the process along. Another possible pitfall is some organizations have gone to a single source supplier on technology related things, or on everything, including technology, rather than doing best of breed. And if you're bringing in a niche kind of boutique application or technology that could be folded into other single source vendors, they might try to talk, and this relates to the next vendor, the next issue, maybe some possible resistance from the incumbent vendors who say, oh, we can do that too. And maybe they can, maybe they can't. And sometimes you've taught the incumbent vendor something that you as a client want, and they can come in and develop a product to match what you as a provider have brought to them from a competing vendor, which kind of cuts out the innovative vendor who's brought the idea in there. So just be aware that that's a possible dynamic as well. And then the final global pitfall slide is lack of senior executive enthusiasm. I've already referenced this. Would you rather manage a nuclear power plant or buy healthcare technology? So you need to anticipate that and try to calm the, kind of calm the seas before that happens, and try to explain and bring these folks on board early on in the process to show them how this actually does accomplish the strategic objectives that the organization has, and have in place a process to manage the operational impact and try to maximize the implementation process. Another problem is extreme sensitivity about security vulnerabilities, especially if a project involves offshore data storage. HIPAA laws or security laws are very different overseas. HIPAA doesn't apply to overseas data storage in most cases, I believe. So a lot of people are running scared of all the security breaches they've seen, and as soon as they see new data that we're collecting and bringing in, that can raise some red flags on their minds, especially, again, if it involves offshore storage of data. And then another one a lot of people don't think about, there's a concern about assuming additional risk. So anytime I have data that assumes additional risk, both from a security standpoint, but also from a patient quality of care standpoint, because if I'm collecting data that I didn't have before on Mrs. Jones, and I'm seeing, and my data stream tells me that she's having problems, she's going out of scope for her clinical condition, I can envision a situation 2 years down the road in front of a trial, malpractice trial, having the attorneys on the other side say, now, Dr. Smith, weren't you aware that Mrs. Jones was having these clinical problems, and didn't you intervene? Why didn't you intervene with that problem that you saw that you had? So don't assume that having additional data is always perceived as a good thing. It is generally, but you have to balance this against the additional risk that this brings about. So, parting thoughts. Technology is one of the few areas where healthcare delivery can actually be improved, and there are hundreds, if not thousands, of small changes that are taking place every week and month and year, and they're resulting in revolutionary changes over time. So the way I like to put it, there may be all these little micro improvements, micro changes that are taking place, and none of them in and of themselves is revolutionizing healthcare, but hundreds of them over time, projecting 5 years down the road, healthcare will look very different than it does today because of these hundreds and thousands of changes that are being implemented all the time. And second takeaway is that there are many, many challenges in getting it done, as we've talked about, and there's many more we can talk about. But finally, it's a great place to be because of all these exciting changes. So that's why I love being in this space. And here's my contact information. As I say, blog every 3 weeks on healthcare technology topics. I'm happy to add you to my list. Just drop me an email and you're on my list, and we're good to go. So I've left 10 minutes at the end for questions and comments. So I'm free to hear what you think and ask me any questions that you might have. And thank you for your attention. So what questions or comments can I try to answer?
Thank you, Glenn, for your time. I do not have any questions in the chat button. Is there any questions or needs out there, anybody? I can certainly unmute you. you have a question, if you want to put something in the chat box, and I can make sure you get unmuted to ask your question. Anything? Nobody's raising their hands, Glenn. I think we're good. As mentioned in the chat box earlier, this session was recorded. The session URL link and the PowerPoint PDF will be communicated and shared with the attendees. So that'll be coming in the next day or so from either myself or somebody on our committee. I think we're good, Glenn. I do not see any questions at this time. Glenn? Glenn?
Okay, yeah, there you go. Yeah, I was muted there. Yeah, thank you everybody for your attention. I hope this has been helpful. And again, I hope you catch my enthusiasm for this topic. Again, I went through it really quickly to try to cover a lot of ground, but I really believe that healthcare will be very different in 5 years because of all the hard work that you folks in the trenches are doing to try to either develop new technology or bring it into the care setting for the purpose of improving patient care and efficiency and reducing costs and all those things. So thanks for your hard work, and thank you for being on this call.
Thank you, everybody, and thank you, Glenn, again. Have a wonderful week, everybody. Bye-bye.